Dr. Cooper, Andrea, you both know how popular our mailbag episodes are, right?
Yes.
Yep.
They're so popular. We have just been inundated with emails from those of you all over the world. And I'm guessing some of you are saying, I wrote 3 months ago. Where is my answer? How come Dr. Cooper hasn't read my email? Well, we've got a solution. I think you're going to love it. Dr. Cooper, tell us what the solution is.
I will. I'm so happy to have found a solution because I feel so badly for all the people that keep writing these wonderful questions and we just can't get to them all. So what we're going to be doing is a monthly live Zoom Q&A on Patreon. So it's going to be available to subscribers of our Patreon channel.
Oh, wow.
Yeah.
Andrea, you do that on Patreon for some other shows.
I do it for a bunch
Tell
of people.
us more about what
Yeah.
it's like.
You sign up for this one. You sign up, and Dr. Cooper will answer a bunch of questions live, and you're going to get a lot of answers and great comments, of course, from Mark, from you and me. And I think it's going to be a lot of fun, and you're going to get a lot of really extra content that I promise it'll be worth it.
And if you've never done Patreon before, it's basically a platform for creators where you can incrementally support shows that you love. So if you go to patreon.com/fatsciencepodcast, you can check out, we've got a couple of different levels. One of the levels starts with a newsletter and the monthly Zoom call. The second level, which is a little bit more per month, actually involves a monthly Zoom call with providers. But anyone can subscribe to that one as well because it's going to be really good information.
Much more in depth.
Much more in depth. And just go to the Patreon platform, sign up to support the show that you love, and benefit from all of the perks. I think you're going to like it.
Hi, it's Dr. Emily Cooper. Are you a healthcare professional who wants to expand your clinical expertise and your approach to treating obesity? Beginning November 7th, I'm offering a 3-part, 20-credit live virtual course through the Diabesity Institute. This course will focus on science-based insights into diagnosing and treating metabolic disorders. I've treated thousands of patients over the past 25 years. Our clinics recorded their outcomes in a comprehensive database, and I've learned a lot that I'd love to share with you. If you're looking for clarity, a greater diagnostic understanding, and effective treatment strategies, for more information and for the official credit statement, visit fatsciencepodcast.com and click on the provider course link at the top of the homepage. All right, now to the show.
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you two.
Hi.
All right, on the show this week, new blood pressure guidelines you need to know about. Andrea, why do we need to know about these?
Because it could save your life.
It really could. You know, the latest data show nearly 1 in 2 Americans has high blood pressure, but only 1 in 4 has it under control. These are just staggering statistics.
High blood pressure is taking a huge toll on Americans' health, and it contributes to nearly 75% of the cardiovascular deaths in the whole country.
So whether you or someone you know deals with hypertension, this episode will help you understand what's different with these new guidelines. I think a lot of us have had our own doctors say, let's keep an eye on this. This is kind of borderline high. But this is really important. We're going to say why it matters and also, more importantly, what you can do about it. And I think as we've gotten ready for this episode, Dr. Cooper, you've talked about early intervention is kind of the driving force behind these new guidelines. But I want to start out with a more fundamental question. To get people to understand, all of us to understand, Dr. Cooper, why not treating high blood pressure is so dangerous.
Yeah, it is really dangerous to overlook high blood pressure and to just kind of brush it off and put off being more aggressive in terms of treatment of it because it's now recognized as, if not the leading cause of cardiovascular deaths, contributing highly to cardiovascular deaths and also other comorbidities. So if you think about high blood pressure, what it means that there's increased tension in the blood circulation of the body, so the circulatory system. So the blood vessel walls are tight and stiff, potentially, and the blood that's flowing through is coming through at a higher pressure than optimal. And so when that high pressure comes through to organs like the kidneys, it can really damage the kidney cells. And the same thing happens if it's going through the coronary arteries. It can damage the walls of the blood vessels of that supply oxygen and blood flow to the heart. So now high blood pressure is linked to all kinds of cardiovascular disease because the high pressure can also cause thickening of the heart muscle, which leads to heart failure. It's also recognized as a risk for increasing the risk for arrhythmias, which are irregular heart rhythms. So hypertension can contribute to a lot of cardiovascular risk as well as the kidney risk. And now they're seeing that it also contributes to vision loss and potentially dementia risk outside of even just the stroke associated dementia. There can be additional mechanisms that could be caused by that. So there are two different kinds of strokes that high blood pressure can contribute to. One is the most common, which is due to like a clot or a plaque that gets loose in there, which is called ischemic stroke, and that's the most common type. But you can imagine the high pressure coming through there can knock plaque off of artery walls, and that can cause a blockage in the brain circulation. But the other type that it contributes to are called hemorrhagic strokes, where that high pressure kind of really damages the capillary walls and blood can seep out into the brain. And so these are all terrible potential consequences of high blood pressure.
Yeah, I think what's also confusing about the new guidelines, Dr. Cooper, is that I think the old guidelines said anything above 120/80 was cause for concern because that was in that sort of borderline zone. But, before we hit the record button, Andrea, you and I were talking about how so many doctors of our general practitioner type doctors, they'll see like we're at 130 over something and they'll say, yeah, this is a little bit high. Let's keep an eye on it, which we don't understand. What does that even mean? Let's keep an eye on it. And why haven't we been more aggressively treating high blood pressure in the past? Because the guidelines were there before, right?
Right. They were there before. But the crazy thing is that a lot of doctors, when we were trained, and not just older doctors like myself, were trained with these higher cutoffs. And so when the higher cutoffs were there, people got used to that being the area of concern. So when the new guidelines came out, actually, not even the new ones, the ones that came out in 2017, the cutoffs were dramatically reduced of when we should be concerned. And it was a dramatic reduction. And so I think for doctors, they were kind of being a little cautious about being too aggressive with people who had blood pressures that previously were thought to be okay. They didn't feel as comfortable applying one medication or multiple medications in people where the blood pressure was in a range that didn't seem that high compared to the older standards. And so I think that influenced a little bit of the attitude. So I feel like these new guidelines are way overdue. It's been like 8 years because they just came out in August 2025. And as I say, they hadn't been updated since 2017. So what's great with the new guidelines is they kept the same cutoffs as the 2017 guidelines. And they said, no, we're really serious about these cutoffs. And I think that is going to help doctors feel much more confident that it is appropriate to be treating hypertension more aggressively, earlier, and more selectively according to the people that are at the higher risk. And so not only do the new guidelines reinforce those cutoffs for the different stages, but they also discussed a lot about how to assess patients who are in gray zones where it's not that high, but it's elevated, or it's in the what's called stage 1 level. Who do you treat? How aggressively do you treat those people? Who do you try to apply like lifestyle strategies alone for initially? And so I think that it provides more kind of emphasis on the stronger, earlier intervention. And I think that's going to really make a big difference.
Like you used to think, oh, 120/80, you're perfect. And
Yeah.
now it's like 120/80, ooh, caution.
Well, yeah, because it's just by 1 point, because so
Yeah.
now below 120/80 is considered optimal. And then, but if you're at 120 to 129 and your diastolic is still below 80, that's considered elevated. So that's in what's called elevated, which means more caution. You wouldn't start a blood pressure medicine, but you would start aggressive lifestyle, you know, advice for the patient's recommendations and see them back and monitor it more closely. Then,
Right.
if you go into the next stage, which is either it's going to be if you have the diastolic number, if it does cross that 80,
That's the low one, right?
that's the low
Yeah.
one. Or if your systolic crosses 130, now you're in the hypertension, stage 1 hypertension. So even if you're at 120 to 129 on your systolic, but your diastolic crossed that 80 mark, you're no longer in elevated, you're in stage 1 hypertension. So it's either or, either your systolic above 130 to 139 technically, and your diastolic 80 or your diastolic 80 to 89. Now that's stage 1 hypertension. And so that group now is looked at a lot with a lot more scrutiny than in the past because with that group, a lot of doctors would say, well, it's not so bad. Let's keep an eye on it. Now the recommendation is we really need to screen who's in that group and determine who needs to be started on blood pressure medicine earlier. And once it gets above that range where you're at 140 over 90 or higher, that's a no-brainer. That's hypertension, stage 2, and you really need to be put on blood pressure medication at that point. And the new recommendations are to be pretty aggressive. Use 2 medicines in that group. And the ideal would be to use a combination medicine so that patients don't have to take like 2 different medicines, because now you can get those 2 medicines in 1 pill typically, and that really does help. But and then of course, if it's higher, like say 180 over 110 or higher, that's like emergency room and super aggressive treatment is done there. But I think what's different with the new guidelines is they did recommend a lot of changes in pregnancy for hypertension, leading up to pregnancy, during pregnancy. So that those guidelines have been kind of re-upped there. But then I think the difference too is in the stage 1 hypertension. Like, how do you figure out who needs to watch that, or do you jump in with medication? And if you do, when do you jump in? So if there's not a lot of risks, it might be good to, of course, apply lifestyle strategies first and then reevaluate 3 to 6 months later. But if the person has a lot of risks, so that could be kidney disease, cardiovascular disease, diabetes, then, it's really important to start the treatment earlier instead of doing that watchful waiting that we used to always do. So they came up with this new calculator to help us determine that.
Let's just say, for example, that you're in the elevated range. Like, what is a lifestyle change that you could do? Let's be reasonable. What is a lifestyle change?
Yeah. Well, one of the really important ones is like eating lots of fruits and vegetables.
Ooh,
I
that's
mean,
not
that
so hard.
doesn't seem hard. The reason behind that is potassium has a lot to do with our blood pressure.
That's in
And
bananas.
yeah,
Bananas,
like almost
spinach.
all,
Spinach?
I don't know exactly, but it's
What?
in all kinds of fruits and veggies, potatoes and
Oh, yeah.
kiwis and um, but if you don't eat a lot of fruits and vegetables, it's likely that your potassium is not really optimized in your diet. And potassium is so important because they found that there's this balance of potassium and sodium that really contributes to our blood pressure. And so we talk a lot about, don't eat so much salt. But what they found is that if you're potassium deficient, then you become much more sensitive to salt in terms of your blood pressure elevations. And so it's even more important to limit salt if your potassium is low. So one concept is to boost up your potassium in the diet. You don't have to take potassium, but just, add Fruits and vegetables, which are the main source of potassium, and make sure you're getting, it's recommended 5 servings a day, and that is a good recommendation for hitting those numbers that you need. And then for sodium, it is recommended now that we get like 2,300 milligrams, which is lower. It keeps going down, the recommendation. So that's like a teaspoon of salt a day. So there are some things like potassium salts that do actually help because they still taste kind of salt. They taste salty, but it's instead of sodium chloride, it's potassium chloride. So that can help a little bit too if you have somebody who has, real problems with hypertension. Manipulating that a little bit can help. But so sodium potassium balance is important. The other thing when it comes to sodium, people don't think of, but it turns out that like almost 90% of the sodium we consume comes from restaurant food or packaged foods. So when we cook at home, supposedly that really is only contributing somewhere between 10 and 15% of our total sodium intake. So that was interesting to me because I didn't realize that packaged foods and restaurant foods sometimes contain other things so it might not even taste that salty. But a lot of things that are used as like stabilizers and stuff like that have sodium in them, and they contribute to the sodium content, even though they don't taste salty. So it's good that's why we're supposed to have to put on the label the sodium content. So that sodium content on the label isn't just coming from salt. It's coming from anything else that's used in that food processing.
Ah. So, Dr. Cooper, when we talk about other lifestyle changes, we're in that elevated range. I'm guessing exercise is good. I'm guessing if you have undiagnosed sleep apnea, that's another thing. Getting a good night's sleep. So let's just break down a list of what's the checklist of maybe top 5 things we can do from a lifestyle standpoint.
Yeah, and you mentioned a lot of that already. So definitely sleep quality, duration, the time that you fall asleep, it's all important for blood pressure regulation, just because it affects the circadian rhythm, which affects our blood pressure, affects our metabolic hormones, which affects our blood pressure. Sleep apnea is a huge problem for blood pressure and other metabolic problems. So definitely treating sleep apnea is critical. And then exercise is beneficial for blood pressure, and it doesn't have to be like a big heavy workout, but even walking and light strength training, being physically active, gardening, like accumulating physical activity helps reduce the blood pressure overall. And stress plays into our blood pressure too, because stress raises what are called catecholamines, which are like fight or flight chemistry that also constricts our blood vessel walls. So trying to do some kind of a stress management program in your life, I think, can be really helpful too. Alcohol. Some people are very sensitive to alcohol in terms of blood pressure. So I've had some patients that if they had even one glass of wine the night before they measure their blood pressure the next morning, it's like 20 points higher. So it varies person to person, but limiting alcohol is really helpful for managing blood pressure too.
I think there's a new thing that's out. I don't know how new it is, but it's a calculator that I found kind of interesting because they also, not only did they have you put in your all your information, but they also had you put in like your zip code and everything because that's important, like where you live and how much access you have to healthcare and stuff like that. Can you talk about that?
Yeah, that's what's one of the most different things about the new guidelines is this new calculator. So we're getting away from some of the older ones that were in use, and this new one is called Prevent, and you can find it online at the American Heart Association. But it takes into consideration some of your biomarkers, but also your zip code, as you were saying, Andrea, because
I thought that
what
was
they found is
interesting.
it correlates because of sometimes zip codes do reflect areas of like the social determinants of health, which means like areas where there's disparity between like the access to care versus other zip codes where care access is readily available. Not just access to care, but access to healthy living. So they've incorporated this zip code tool also. And so the calculator, I mean, it's a fairly new calculator. So We don't really know. We won't know for a long time how well that calculator holds up, because the old calculator that we use, which was like the ASCVD calculator, they're saying this one is better. So eventually they'll find another calculator. But this is meant to help doctors really determine which patients need more aggressive treatment when they're in that stage 1 range, especially. So, yeah. And so I was wondering, do you guys want to do your
Right. Like,
numbers in the
didn't you try
calculator?
and put in our numbers and see what
Yeah.
did we get? What
Well, we,
what did we get? Did we pass? Did we
yeah.
get?
And the place to find the calculator, it's just on the American Heart Association website. So if we do yours, what's your
Yeah.
age?
So I am 68.
There's no hiding here on the
I
podcast.
am always an open book. I'm an open book.
Oh. And then I'm going to put in your numbers. It asks for cholesterol. Now, when I was working
What
with the
was my
patient,
cholesterol last time?
it was
You have
136.
my numbers.
136. I've got your.
Okay.
Oh, sorry. No, that was Mark's. I'm sorry. Let me do yours. Yours was 114.
Woohoo!
Yeah, which is very low. Then it asked for, oh, you know what, Andrea, the
What?
calculator doesn't work for you because your cholesterol's too low.
Oh well.
This is what happened to me with a patient the other day. I was trying to plug it in and it will not accept under 130.
Why?
Well, so that's a flaw with the calculator because a lot of patients are on treatment and they're going to have low
Oh,
levels.
because
But
I take a lot of drugs, everyone.
yeah, but that doesn't matter. Some people could still
Yeah,
be
I
at
mean,
risk.
I'm under a lot of doctor's care.
Yeah, but you did have, you did have a good HDL also. Your HDL cholesterol was 66, and your systolic blood pressure was right at that 120. Your
Right.
kidney filtration was really good, and your BMI, wasn't elevated now. So,
Yeah.
so this could be yours. If we could have plugged it in, it would probably show low risk.
Right.
Now, let's try Mark because then
But
maybe.
mine, which shows the only reason mine shows low risk at this point is because I'm on a lot of correcting drugs.
Yeah.
Yeah, exactly. And so let's plug Mark's in. Actually, Mark, your total cholesterol, I'm not sure. I think it was, it looks like I missed that one, but let's put 130. It wasn't high. I know that. Let's put 130. What's your age?
61.
Okay. And your HDL was 48. Your systolic pressure was kind of high last time when we saw you in the clinic, and so it was 136.
Yeah.
And your BMI, I'm putting that in. I don't want to say the BMIs. It's kind of silly because we don't believe in BMI. We're trying to not be weight focused, but your BMI was basically normal, what I consider normal for males.
You know what's interesting about blood pressure too?
Yep.
I've for years suffered from what they call white coat syndrome.
Oh, yeah.
That when I go to the doctor, it's always higher
Yep.
than when I'm sitting at home at the kitchen table taking
Oh,
it.
yeah.
So,
Let's talk about that once we do the calculator. Let's talk about measuring your blood pressure at home.
yeah, let's do that.
Yeah. But so diabetes, you don't have diabetes now. You don't smoke currently. You are on blood pressure medicine, right?
Mm-hmm.
Yep. And you are on cholesterol medicine. So those are questions it asks.
Yes.
And then your A1C has been really good. So I'm going to plug that in. Okay. And now I'm calculating. So you came out with a 10-year risk at 4.3%, which is considered good. So if we had just seen you, and you were, you weren't, I mean, it's saying, it knows that you're on blood pressure medicine actually now because we said you are, but it's calculating you at 4.3, which is actually good because if it's 7.5 or higher, that's the group that's more at risk, that the most at risk. And I think yours came out good because some of your markers are looking good now. So, but I encourage people to run that calculator if they can. You have to have access to your lab work. And so the lab work really doesn't have to be extensive. It just you need the A1C, HbA1c. You need the basic metabolic panel that gives you the estimated GFR, which comes from your kidney function test. It's a very basic test everybody usually has. Your total cholesterol, your HDL, and your systolic blood pressure. And beyond that, you can answer the questions there and see where you fall. And so, but yeah, and you were talking about measuring your blood pressure at home and the white coat syndrome. What's real interesting is white coat syndrome is when you go to the doctor and your blood pressure is elevated there, but not when you're at home. And whether that should be treated or not is like always a question. And there have been some studies that showed that people with that are at higher risk, even though they're normal when they're home. And so it isn't just so cut and dry, like, well, since it's fine at home, there's not a risk. That's not really true
Yeah.
because it means that your blood pressure can just go up in different instances.
Yeah, it
And
responds quickly to stressful situations, right?
yeah, exactly. Right. And so the other thing to keep in mind is if you're not on blood pressure medicine, the blood pressure is normally at its highest when we wake up in the morning to just get us out of bed with our cortisol surge that helps give us energy to help us get out of bed. So those early or morning, within an hour of waking up, our blood pressures are going to be the ones that show the hypertension the most usually. If it's not elevated then and it's elevated at the end of the day, it usually means your stress levels are just what's really contributing to it. And maybe you could make some progress reducing the stress. But home measuring is a feature of the new guidelines too. They're emphasizing the importance of home measuring and doing it accurately. Because a lot of doctors a long time ago would poo-poo the home readings and be thinking that's not accurate. But now we know that's usually more accurate if it's done properly. And so part of the new guidelines is there's a reference to a new tool for people to look up different kinds of blood pressure monitors that are validated. I think it's called validatebp.org. And so it lists all kinds of brands of blood pressure medicines that they have validated that are accurate. So, and it includes a lot of readily available meters that you can just get online. And it's preferred to use a cuff meter, not the wrist ones. The reason is the wrist ones can often read high, and they're just not as accurate. So you want to get a cuff meter that's the right size because so you have to measure your arm circumference, make sure it's the right size. They're usually marked where it would show you if it fits or not. And there's a whole process to do to take your blood pressure accurately. So just taking it here and there haphazardly isn't the right way to do it.
So now your doctor says you have hypertension, you have a problem. What happens? You're on the medication. What do you need to know? What's going on? What are the medications and what do you need to know? What's next?
Well, the medications, there's lots of different ones now, and mostly generics. You don't really need to spend a lot of money on blood pressure
Right.
medicine, fortunately. And we have lots of different options of ways to lower the blood pressure. Some of them work through systems that change your kidney approach to blood pressure control. Some affect the vasodilation, the blood vessel wall, helping it relax. Some affect the way the heart pumps. Some are diuretics. So there's all kinds of different ones, and those are selected by doctors based on your overall health history and all of your what are called those comorbidities. So if you lean towards kidney problems, there may be certain medications that are recommended above others. If you lean towards cardiovascular problems, there's other medications that are recommended typically. So one of the problems is some of the groups of medications that are common, which are the beta blockers, they can cause a lot of fatigue. And so that can be a problematic side effect. But sometimes the beta blockers are really necessary because of some type of cardiovascular risk that a patient has. So I think these are just discussions to have with your doctor and to make sure that the medicine that's being chosen for you, that you understand why that particular one is being chosen, how does that affect your overall health, and what would be the potential side effects? Are there alternatives that have less side effects? But in general, blood pressure medicines don't have a whole lot of side effects typically. They're usually well tolerated. And as I say, we have so many options now. And so I think that that part is not too hard for the doctors to figure out how to get you started on something. The difference is that now with stage 2 hypertension, it's recommended to approach it with 2 medicines, not just one, where before we used to use one. And some people need to get up to 4 medicines to control their blood pressure. There is something called resistant hypertension. And so it's really a science for the doctor to figure out how to get this blood pressure under control. So there isn't really a one size fits all, just like we say with
Right.
everything in
Right.
medicine.
Exactly. I'm on 3 different ones.
Yeah.
Well, I don't think so. You're not on
Aren't
3
I?
different blood pressure medicines. No, you're on
Those
1
aren't
blood
the.
pressure and two for your cholesterol.
Oh, it's cholesterol.
Yeah,
Oh,
people get it
sorry.
confused and think that
I
sometimes,
well,
yeah, but they're both cardiovascular.
right.
Yeah, that's really interesting, Dr. Cooper. Like when you talked about some act as a diuretic, so that's regulating the fluid levels in your body, and
Yes.
some are targeting the heart, and some are targeting the
Yeah.
circulatory system walls. What I think is interesting too, Dr. Cooper, is the connection between blood pressure and metabolic syndrome and
Yes.
metabolic dysfunction. So, blood pressure is one of the variables that contributes to the definition of metabolic syndrome. So, I think we should talk about blood pressure's role in metabolic dysfunction. That there's a real strong connection there, isn't there?
There really is. So that's what I always am questioning. Because if we think of high blood pressure, most high blood pressure is called essential hypertension, which means it's just there. It's genetically determined by multiple genetic factors. There's strong family history. And but there is we didn't mention, just a side note, is there's a small percent that's secondary hypertension. And that means that the doctor is going to be looking for possible other causes of this hypertension. So not so much related to the metabolic syndrome, because with metabolic syndrome, that's typically essential hypertension as the component of metabolic syndrome. But for secondary hypertension, it's usually endocrine based. And so it could be related to a hormone called aldosterone, which regulates our fluid and salt balance and things. Or it could be something like Cushing's syndrome. We had a person on describing her Cushing's syndrome that she had, which is an adrenal adenoma that secretes cortisol. So there can be endocrine reasons for high blood pressure that we don't want to overlook. And so it could be parathyroid hormone, which is a hormone that controls our calcium levels. So when doing the initial evaluation, I always look at, is there any sign of a secondary problem? And the new guidelines emphasize that we should be looking closer for secondary hypertension. That's a difference also with the new guidelines. So that means if a person has something with their fluid and potassium levels, maybe they have maybe they have that endocrine cause with the aldosterone problem. Or if they have a high cortisol, maybe they have a Cushing's type of thing. So it's always looking for a secondary cause that's not the typical essential hypertension. But aside from that, the other thing I look at is whether this hypertension is a component of the metabolic syndrome, as you were describing, Mark, because metabolic syndrome is defined as having 3 of like 5 different variables occurring together, co-occurring, and one of them is hypertension. And what's interesting with the prevent calculator we just did, it asked about HDL, because HDL is another metabolic syndrome indicator if it's low. Glucose, and the prevent calculator asked about A1C. So in a way, the prevent calculator itself is sort of leaning towards trying to find who has metabolic syndrome in that calculator. So with elevated blood pressure, elevated A1C, low HDL, this is now like shouting metabolic syndrome. And the importance of looking at it that way is to see that there's a metabolic basis to this hypertension. So it's still genetic, but it's not an isolated issue. The genetics isn't just isolated to just hypertension. It's affiliated with glucose regulation issues, cholesterol issues, all together as a constellation. And so I think it's important to look at it that way, because it means if we target the treatment towards the metabolism, not just put someone on any old blood pressure medicine, we're going to see better results. And so targeting that metabolic syndrome will improve the blood pressure regulation. So even if you're targeting it with something that's not even a blood pressure medicine, like a GLP-1 or metformin, you're going to see improvements in the blood pressure.
So you're saying that someone with metabolic syndrome who starts on a GLP-1, they may actually see a reduction in blood pressure.
Yes, absolutely. They may see a reduction in blood pressure. And a lot of it, if you think about metabolic syndrome, and we talk about metabolic dysfunction associated with obesity and things, well, a lot of the chemistry of that could drive the blood pressure up because high insulin levels, insulin promotes high blood pressure. If it's elevated, because insulin is what's called an anabolic hormone. So it also helps like build up and preserve your muscle tension somewhat. And so it contributes that way, but it contributes other ways too to the vascular dynamics of how the blood vessels contract and release and all that. But another hormone, adiponectin, which we've talked about before, adiponectin is like our body's own metformin that it makes. And it comes from our body's fat cells. And it's influenced a lot by our environment. So, like if we're exposed to those endocrine disruptors, it can drop a lot. But adiponectin is very protective against hypertension and against cardiovascular disease because it serves as an anti-inflammatory for our blood vessel walls. So it prevents inflammation of our blood vessels, and it also improves what's called endothelial function, which is the inside muscle layer of our blood vessels, how it functions to contract and expand. And so, and that's a huge feature. Low adiponectin is associated with metabolic syndrome, diabetes, obesity. So that is an endocrine hormone from our body fat. And others like the starvation signals we talk about, AGRP and NPY, those are neuropeptide Y and agouti-related peptide from the brain, the hypothalamus. Those are hunger signals. They're called orexogens. And when those are elevated, they also contribute to the high blood pressure. So it's very interesting, when you start looking at all of the ways that the metabolism has its tentacles on our blood pressure responses and things. So looking at it as hypertension isolated is really important because we do want to make sure that's under control, that aspect of our health. But then seeing the bigger picture of how it fits into our whole metabolic system is also really important.
Wow, that's really interesting. Well, as we start to wrap things up, I'd love to just know what your takeaways are, you two. Andrea, what's your takeaway from our episode today?
Well, first of all, I never knew that blood pressure and the kidneys was a thing. That was news. But, I mean, it makes total sense, obviously, but I didn't know, so that was news to me. But as we get, as we're moving forward and we get older, it's just, we really have to pay attention and really look at blood pressure and keeping it in control and making sure that we pay attention. It's just so important to our overall health and our overall well-being.
Absolutely.
Yeah. Dr. Cooper, what's your takeaway?
Well, the one thing I'd like to point out is that the home readings are very valuable. And so I really encourage people to look at that Validate BP site, find a good, meter that you can get. They're not very expensive. If you have hypertension, your doctor can write it as a prescription, and it's usually covered by insurance under that diagnosis. But to keep in mind, when you check your blood pressure, there's a whole set of things you're supposed to do. Empty your bladder. Believe it or not, you should make sure your bladder's empty. Sit in a chair for a few minutes, resting, with your feet planted on the ground, flat, not cross-legged. You should have your arm supported by some kind of a surface that's heart level, right in front of you. And the cuff should go on correctly according to the manufacturer instructions, and it should fit you correctly. And so then you want to check. They're recommending 2 or 3 measurements each time because they can vary, And so what you want to do is if you get one and the second one is kind of different, get a third one. And just make sure you're really resting, not talking, none of that. And doing morning and evening measurements is important too. So keep a log. So get some within an hour of waking, some before bed, and show those to your doctor and see if there's any concern, especially if you're above the 120/80 mark, or if you're at 120/80 or higher. Get some input on that.
Okay. I think the big takeaway for me is that, for years I was borderline high, actually high blood pressure, and it was left untreated. And, the thing that's most concerning about this is that some of this damage caused by high blood pressure is not reversible. I've had friends who've had strokes and kidney problems and stuff like that. So knowing your numbers, catching it early, treating it early has profound impacts on your future health. So don't live with borderline, you guys. If your doctor says, hey, let's keep an eye on this, maybe
Push.
say, well, maybe let's do more than keep an eye on this. If we're into the gray area, maybe we should treat it. All right. Thanks, you two, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.